presenting to you a simple, effective, and novel method of MPFL reconstruction which avoids the use of implants or bone tunnels and can be used in all age groups, including those with wide open physis. My disclosures. The MPFL is the primary medial static stabilizer of the patella. Insufficiency of the MPFL leads to lateral patellar instability. Anatomical studies of the MPFL have shown that the fan-shaped ligament, which is in the second layer of the medial retinaculum, attaches onto the femur in the region in between the adductor tubercle and the medial epicondyle. On the patellar side, it has a soft tissue insertion into the vastus intermedius besides the upper half of the medial border of the patella. Various methods of reconstruction have been described in literature using various grafts, single or double-stranded constructs, using bone tunnels or soft tissue fixation, and using various implants. However, bone tunnels are not advisable in cases with open physis. It adds to tissue trauma, and implant-related complications are known to occur. Similarly, on the patellar side, bone tunnels are not advisable in the skeletally immature and hypoplastic patella. They increase the risk of patellar fracture, and implant-related complications are known to occur over here as well. Isolated implant fixations in the patella are non-anatomical, since they do not have any soft tissue insertional component of the MPFL complex into the vastus intermedius. Use of implants leads to rigid fixation, which can result in an over-constraint and complications due to increased patellofemoral joint reaction forces. The implant material itself may give rise to complications, and therefore the use of implants is best avoidable. Soft tissue techniques using the adductor magnus or the medial collateral ligament as a sling are non-anatomical, since the site of insertion of the MPFL is in between the adductor tubercle and the medial epicondyle. Use of radiography, like the Schottle's point for locating the femoral insertion, is known to be erroneous since it is not accurate in at least 25% of cases. Its use is therefore avoidable. It is also not applicable in cases with open physis. The use of quadriceps tendon as a graft is best avoided to prevent an already compromised extensor apparatus from getting compromised further in cases of patellar dislocation. Results of MPFL reconstruction have been compromised either due to non-anatomical nature of the construct, non-physiometricity due to abnormal tensioning of the graft, surgical errors due to intraoperative use of radiography, or complications arising as a result of implants, bone tunnels, or morbidity of graft harvest. In order to overcome these drawbacks and complications to better the results, a novel basket weave technique of MPFL reconstruction was devised. This gives us a complete anatomic reconstruction with a physiometric construct replicating normal tensioning of the MPFL with only soft tissue fixation. It avoids bone tunneling, implants, and intraoperative use of radiography, and therefore the related complications are completely avoided. The technique is as published in the Journal of Arthroscopy Techniques. The cases included in our case series were of recurrent patellar dislocations, first-time patellar dislocations with laterally dislocatable patella, symptomatic laterally subluxating patellae not responding to appropriate rehabilitation, and previously failed soft tissue procedures like lateral release and medial plications. Cases excluded were of congenital habitual dislocations, chronic irreducible patellar dislocations, and those having patellofemoral arthrosis with primary complaints of pain and cases undergoing trochleoplasty. However, the procedure can be performed along with a trochleoplasty if necessary. Coming to this case example of a 16-year-old female with left knee recurrent patellar dislocation, she had a primary injury 1 year ago with the last dislocation 2 months prior to surgery. She complained of instability, pain, and intermittent locking of the knee. She had difficulties in climbing and descending stairs. On examination, she had a full range of motion, minimal swelling, tenderness at the medial epicondyle, increased lateral patellar mobility with an apprehension test positive, normal medial patellar mobility, no limb alignment abnormality with a normal Q angle, and there was no other ligamentous laxity. X-rays did not reveal any significant abnormality. 3D CT reconstruction confirmed normal trochlear anatomy. Superimposition CT showed a normal tibial porosity trochlear groove distance and absence of any torsional deformity of the femur or tibia. MRI confirmed the MPFL injury at its femoral insertion, and rest of the MRI findings were normal. An isolated MPFL reconstruction was therefore planned for this case using the basket weave technique. Coming to the surgical technique itself, the surgery is carried out under general anesthesia with a pneumatic tourniquet and a standard arthroscopy positioning of the left leg in a leg holder. Examination under anesthesia reveals a laterally dislocatable patella with a normal medial mobility. Arthroscopic visualization through the anterolateral portal reveals a normal trochlear groove and a laterally tracking patella with a lateral overhang. A chondral loose body is found in the lateral compartment, which is removed. A pretensioned autologous hamstring graft is used with the gracilis preferred over the semitendinosus, except for the obese and non-athletic females where the semitendinosus is preferred over the gracilis to avoid any graft insufficiency. The graft is harvested using a cosmetic posterior mini incision technique, or as in this case, the standard anteromedial approach is used. Graft preparation is done on the back trolley and the graft is kept for pretensioning. This schematic representation of the medial aspect of left knee shows structures deeper to the first layer of the medial retinaculum. The native MPFL is in green. The yellow region depicts the ligamento-periosteal area in between the adductor tubercle and the medial epicondyle. This is formed by decussation of fibers from the insertions of the medial collateral ligament distally, the medial patellofemoral ligament anteriorly, the adductor magnus proximally, and the medial gastrocnemius posteriorly. The patellar skin incision is at the medial border of the patella, and the femoral incision is over the region in between the adductor tubercle and the medial epicondyle. The first layer of the medial retinaculum is then incised just medial to the medial border of the patella. As the plane is formed between the first and the second layer of the medial retinaculum, one may be able to identify the native fibers of the MPFL with their superior and inferior extent. The knee is kept in 90 degrees of flexion, and the bony landmarks of the adductor tubercle, medial epicondyle, and the distal edge of the medial femoral condyle are palpated prior to taking the femoral incision. A centimeter thick ligamento-periosteal sleeve is then elevated from the region in between the adductor tubercle and the medial epicondyle. Prior to elevating the sleeve, one reconfirms the position of the adductor tubercle and the medial epicondyle by palpation. Using sharp dissection, an incision is taken just anterior to the region, and one then elevates this ligamento-periosteal sleeve. The pretensioned hamstring graft is then looped underneath this ligamento-periosteal sleeve using a mixture forceps to its halfway mark. And as we can see here, the ligamento-periosteal sleeve of tissue is thick and strong to hold the graft very well. The two limbs of the graft are then shuttled into the patellar incision underneath the first layer of the medial retinaculum using the tissue elevator graft passer. Each limb is shuttled separately to avoid any inadvertent twisting of the graft while shuttling in between the two incisions. The graft is then fixed on the femoral side to the ligamento-periosteal sleeve using a number 1 braided absorbable suture material by a pretzel stitch. The opening in the first layer is sutured back over the graft fixation point at its anatomical location, thus completing the femoral fixation. Alternate sleeves of extensor retinaculum are then elevated on the anterior surface of the patella. The proximal sleeves are just proximal to the superior pole of the patella, and the distal sleeves are at the level of the middle third of the patella. The first elevated sleeve is always the medialmost one for both the superior and the inferior sleeves. This will ensure that the first point of graft fixation is deep and not superficial to the extensor retinaculum. The extensor sleeves are elevated using sharp dissection with a 15-number blade. The tissue elevator suture passer device is used to ease the passage of graft underneath the sleeves and reduce the number of steps required for graft passage. One would require to elevate 2 sleeves at least for the proximal row and 2 sleeves for the distal row. Once the graft is weaved into the alternately elevated sleeves of the extensor retinaculum, it forms a basket weave kind of a pattern on the anterior surface of the patella as we see here, and hence the name, the basket weave technique. The proximal limb of the graft is fixed, keeping the knee in 30 degrees of flexion and the patella centralized. The distal limb of the graft is fixed, keeping the knee in 90 degrees of flexion. This ensures that the graft placement is physiometric. The graft is fixed using a Pranjal stitch at each level. This stitch helps to reduce the number of sutures and knots on the anterior surface of the patella. It transfixes and cinches the graft to the fixation point using a single stitch. A number 1 braided absorbable suture material is used for suturing. The first pass transfixes the graft. The second pass cinches the graft as it goes around the graft, and the third pass transfixes the graft again. The residual redundancy of the first layer of the medial retinaculum is removed by plicating it onto the extensor retinaculum over the anterior aspect of the patella. This suturing is done while keeping the knee in 30 degrees of flexion. Finally, the excess limbs of the graft are excised, and that completes the procedure. One confirms that the normal patellar stability, mobility, and tracking are restored. Arthroscopically, one can visualize the ligament construct to be extracapsular and anatomical. The patellar tracking is centralized and there is no lateral overhang. Postoperatively, the knee is kept in a rigid long knee brace with the knee in 30 degrees of flexion, permitting partial weight bearing till suture removal. Following suture removal, the knee is in full extension and one may start with full weight bearing. The knee brace can be discarded as soon as good quadriceps control is achieved. Active range of motion exercises can be started from the next postoperative day within the painless range as tolerated. Full range of motion is usually achieved by 4 to 6 weeks in isolated MPFL reconstructions. Quadriceps and vastus medialis toning exercises as well can be started from the next postoperative day. On an average, return to sports would be by 4 months postoperatively. In our case series, one patient developed a fracture of patella 8 months postoperatively following a fall from stairs. Intraoperatively, one could find that the ligament reconstruction construct was still intact and one could go ahead with a standard K-wire tension band wiring fixation. This reflects on the strength of the construct and it does not interfere with any secondary procedure if required over the patella. The clinical results of our prospective study using this technique is published in the Indian Journal of Orthopedics. 62 knees were followed up over an average of 24 months. The youngest case was 9 years of age and the oldest of 48 years. The average koala score improved from 65.4 to 99.6. 20 knees required loose body removals or chondroplasty. 47 knees had a trochlear dysplasia, however this was not addressed. 6 knees required a lateral retinacular release, 5 a tibial tuberosity transfer, 1 an associated ACL reconstruction, and 1 a distal femoral derotation osteotomy. The average KU score improved to a near normal level in all parameters except for sports and recreation. As compared to other series of MPFL reconstruction in literature, this technique has shown a significantly lower complication rate and therefore also a high koala score. The technique has a number of advantages. It is precisely anatomic at the femoral and patellar insertion points as well as the course of its construct. The technique results in a Y type of graft construct. This allows differential tensioning and fixation of both limbs of the graft in different degrees of flexion. It therefore stabilizes the patella in all degrees of flexion, restoring normal physiological tensioning of the reconstructed MPFL. Due to the soft tissue fixation, it provides for better proprioceptive feedback. Due to a non-rigid fixation, it avoids the possibility of any over-constraint and ensures normal mobility and tracking of the patella. There are no bone tunnels or implants, therefore all the related complications are avoided. It does not rely on intraoperative radiography, therefore the surgical errors are minimized, it reduces the operative time, and there is no exposure to radiation. It can be performed in the skeletally immature and cases with hypoplastic patella. Even in presence of patellofemoral arthroplasty, this procedure can be performed. It does not interfere with any secondary surgery or resurgery on the patella or the femur, as it does not use any implants or bone tunnels. It is also an economical procedure. So as we see, this technique of MPFL reconstruction has a number of advantages over other methods of reconstruction. It restores normal patellar stability and mobility with least risk of complications. It is a reproducible and reliable technique with good to excellent results. So possibly a preferable method of MPFL reconstruction wherever indicated.